Hello everyone. Welcome to Propranolol, a comprehensive overview. I am Doc Saab and today we will dive into this versatile beta blocker, a cornerstone in cardiovascular and beyond. Propranolol, discovered in 1960s by Sir James Black, revolutionized the treatment of heart conditions and expanded to off-label uses like infantile hemangiomas. We will cover its mechanism, uses, dosing, side effects, and more, drawing from established pharmacology to guide you for clinical practice. Let's get started. First, what is propranolol? It is a non-selective beta-adrenergic receptor blocker, commonly known as beta blocker. As a class, beta blockers like propranolol counteract the sympathetic nervous system's effects, which are mediated by catecholamines like epinephrine and norepinephrine. This is crucial in conditions where sympathetic overactivity drives pathology such as hypertension or arrhythmias. Propranolol's broad action makes it a go-to for both cardiovascular and neurological issues. In medical education, remember it is a sympatholytic agent, reducing heart rate and blood pressure by blocking beta receptors. We will explore its role in detail next. Propranolol's mechanism is straightforward yet profound. It is a competitive antagonist at beta 1 and beta 2 adrenergic receptors. By binding to these sites, it prevents epinephrine and norepinephrine from activating them, effectively dampening sympathetic responses. This leads to a reduced heart rate, contractility, and blood pressure, key for managing conditions like hypertension. At higher doses, it may have membrane stabilizing effects similar to local anesthetics, though this is less clinically prominent. For medical students, think of it as a putting the brakes on the fight or flight response. Its lipophilicity allows rapid absorption, but first pass metabolism limits bioavailability to about 25%. This mechanism underpins its efficacy across multiple systems. Let's break down the cardiovascular specifics. Beta 1 blockade in the heart decreases heart rate and myocardial contractility, lowering oxygen demand and preventing angina. For hypertension, propranolol reduces cardiac output and renin release, inhibiting the renin-angiotensin system. In anti-anginal use, it delays ischemic pain by improving oxygen supply-demand balance. Clinically, this is why it's a first line for hypertensive patients with tachycardia or those post-MI. Remember, in arrhythmias like atrial fibrillation, it controls ventricular rate without directly converting rhythm. These effects are dose dependent and reversible, making a propranolol safe for long-term use when monitored. Beyond the heart, propranolol's beta 2 blockade causes vasoconstriction, which can paradoxically worsen peripheral circulation in some cases. In infantile hemangiomas, it induces vasoconstriction, inhibits angiogenesis via VEGF suppression, and promotes apoptosis, explaining its off-label success in shrinking these benign tumors. It is also modulates the renin-angiotensin system by reducing renin secretion, contributing to antihypertensive effects. For a neurological uses like essential tremor, it blocks central beta 2 receptors to reduce tremor amplitude. These multifaceted mechanisms highlight propranolol's versatility but always consider the balance between benefits and potential side effects like bronchoconstriction. Pharmacokinetically, propranolol is a highly lipophilic with 90 to 95% oral absorption but high first pass metabolism, only 25% reaches systemic circulation. It is metabolized in the liver via CYP2D6 to inactive metabolites like naphthoxylactic acid excreted renally. Half-life is 3 to 6 hours for immediate release, longer for sustained release. In a liver cirrhosis, bioavailability increases due to reduced metabolism, dose reduction needed. For hypertensive patient, sublingual administration bypasses first pass, enhancing availability. Population studies in pediatrics show linear kinetics up to 120 mg. As a resident, consider these in polypharmacy such as CYP inhibitors like fluoxetine can elevate levels. Steady state takes 2 to 3 days, monitor in renal impairment. Propranolol shines in cardiovascular care. For hypertension, its use alone or with other agents to lower blood pressure, reducing stroke and MI risk, typical starting dose 40 mg twice daily. In angina pectoris, it prevents chest pain by decreasing myocardial workload with maintenance 80 to 320 mg daily. For arrhythmias, it controls supraventricular or ventricular tachyarrhythmias, especially in digoxin toxicity, though alternatives like amiodarone are often preferred due to propranolol's limited role here. Post-MI, it improves survival by preventing further events. In hypertrophic subaortic stenosis, it alleviates outflow obstruction. These uses are evidence-based per guidelines like those from the ACC or AHA, and propranolol's oral bioavailability makes it practical for outpatient management. Expanding to neurological and other areas, propranolol is a migraine prophylaxis drug starting at 80 mg daily, reducing frequency by 50% in many patients. For essential tremor, it is first line dose 40 to 160 mg daily, improving fine motor control. In a thyrotoxicosis, it counters hyperthyroid symptoms like tachycardia and tremor, performance anxiety off level. It blunts physical symptoms like rapid heart rate. And for infantile hemangiomas, it is now standard starting at 0.6 mg per kg twice daily in infants. These off label uses, while not FDA approved for all, are supported by robust evidence, such as in hemangiomas, it is superior to corticosteroids. As a family medicine resident, you will encounter this often. Always screen for contraindications. Dosing propranolol requires tailoring to the condition and patient factors like age and liver function. Immediate release 10 to 40 mg 3 times daily. Sustained release 80 to 160 mg once daily. For hypertension, start 40 mg twice daily. Titrate to 120 to 240 mg total daily. Angina 80 mg once daily initially up to 320 mg. Migraine 80 mg daily, maximum 240 mg. Arrhythmias 10 to 30 mg 3 times daily or IV 1 to 3 mg over 1 minute. In pediatrics for immunogiomas 0.6 to 1.7 mg per kg twice daily. Use slow release for once daily convenience but monitor for compliance. Key tip, titrate slowly to avoid rebound hypertension. Guidelines emphasize individualization, such as in elderly or renal impairment, start low. Always check for interactions like with calcium channel blockers. Side effects are generally mild but warrant vigilance. Common ones include fatigue, nausea, dizziness, and GI upset, often transient. More serious, bradycardia, hypotension, or heart failure exacerbation, especially in decompensated patients. Allergic reactions like rash or swelling are rare but possible. Raynaud's phenomenon can occur due to vasoconstriction. In infants, monitor for hypoglycemia. For medical students, remember beta blockers like propranolol can mask hypoglycemia symptoms in diabetics. Report any chest pain, confusion, or lightheadedness immediately. Overall incidence is low with proper monitoring, but educate patients on self reporting. Propranolol is a contraindicated in cardiogenic shock, sinus bradycardia with AV block, and bronchial asthma due to beta 2 blockade and hypersensitivity. In infants under 4.5 lbs per oral liquid, avoided due to formulation risk. It is also off limits in decompensated heart failure or severe COPD. For family medicine, screen for asthma history before prescribing. Use cardioselective blockers like atenolol instead. In pheochromocytoma, it is contraindicated without alpha blockade first to prevent unopposed alpha effects. Always review allergies and comorbidities. Abrupt withdrawal can cause rebound hypertension or MI. These are absolute no-goes. Double check charts. In summary, propranolol is a non-selective beta blocker with broad applications in hypertension, angina, arrhythmias, migraines, and more. Thanks to its beta 1 and beta 2 blockade. Dosing is flexible but requires titration and monitoring for side effects like bradycardia. Contraindication include asthma and shock, and its pharmacokinetics demand caution in hepatic issues. As we have seen, it is powerful tool in family medicine from preventing MI to managing tremors. Future perspective point to personalized dosing via pharmacogenomics. Thank you guys. If you have any further questions, contact me via comments or DM me on Instagram for further discussion. And please like, share and subscribe to the Doc Subs Diary.